First of all, I would like to thank the organizing committee for the third annual conference of the Egyptian Society of Organ Transplantation. Today I'm going to discuss with you the value of donor-specific antibodies, either pre-formed before transplantation or newly formed after transplantation as de novo, and their role in kidney transplantation. I'm going to discuss this topic under the following sectors: introduction for the value of these anti-HLA antibodies, risk factors for the development, classification and values, what are their types and the correlation with the types of acute antibody-mediated rejection, then how to optimize interpretation, few words about non-traditional and non-HLA antibodies, and I'll end with conclusion. To start with, this is our humble experience from Mansoura Urology and Nephrology Center, a work led by Professor Muhammad Ahmad Ghunaim. In this work, we had already transplanted 153 patients. We knew their follow-up well, and the sera of the patients before transplantation were preserved at our lab. Then we applied the Luminex technology to detect the presence or absence of anti-HLA antibodies, and by comparing the tissue typing of the donor, we can know is it specific or not. We found that the presence of donor-specific antibody was bad news because it was associated with significantly higher percentage of acute antibody-mediated rejection within the short period after transplantation. And even if the flow cytometric mismatch, as you see in this study, the presence of donor-specific antibody above the 3000 mean fluorescence intensity. Mean fluorescence intensity is a reflection of the concentration of the antibodies. If it is above 3000, as you see here, the risk of acute rejection is higher. So even if the flow cytometric mismatch negative, the presence of donor-specific antibody, especially if it is present with high concentration, can predict the occurrence of antibody-mediated rejection. This study showed that the presence of donor-specific antibodies may predict the occurrence of delayed graft function. Very interesting point. It is not only the presence or absence of anti-HLA antibody, but their persistence. Here, these are the risk factors for persistence of donor-specific antibodies: female sex, age at transplantation below 50 years, preformed DSA above 3,500 mean fluorescence intensity, preformed class 2, presence of pre-transplant sensitizing event, presence of more than one preformed DSA. All these are risk factors for persistence of DSA. And this study, although it included few number of patients, but showed that persistence of donor-specific antibody is very bad because it adversely affects significantly the outcome of transplanted graft. Here, the graft loss, the hazard risk for graft loss is 5.7 folds. Again and again, if we compare donor non-specific to donor specific, you can find here the answer. The presence of donor specific is bad and associated with poor graft survival. It's not only as I mentioned before, it's not only the presence or absence, but also the strength and concentration of anti-HLA antibody as reflected by mean fluorescence intensity. So if mean fluorescence intensity above 3000, you can find the drastic affection of the graft outcome. And here you can look the presence of no donor-specific transient below 3000 mean fluorescence intensity, between 3 to 6000, above 6000, and you can correlate here presence of donor-specific antibody, especially if above 3000, is associated with graft failure or decreased graft function, acute active antibody-mediated rejection, and chronic active antibody-mediated rejection. Even the presence of donor-specific antibody that developed after transplantation is bad news, and we will not treat this DSA because of the presence of DSA, but we should put the patient on focus, because these patients, according to this study, may develop will established antibody-mediated rejection later on. So the message from this study, when we diagnose de novo DSA, we should follow these patients. Even 1 year protocol biopsy after the detection is elegant because it may detect the presence of the pathology. And this slide shows the factors, risk factors for the development of de novo DSA. As you see, the more the mismatch here for DR, the higher the risk of development of anti-Chilaidin antibodies. So it's better to select good matched couples. And the presence of acute cell rejection after transplantation is bad news because it stimulates the immunity toward antibody-mediated as well. Documented medication and adherence is very bad, and we should put it in our agenda to educate patients to be adherent to their treatment, because non-adherence is a significant risk factor for both development of de novo DSA and in other studies graft loss. And even in the current BAMF, the BAMF 2015 that was published in the American Journal this year, the diagnosis even from previous BAMF for antibody-mediated rejection is dependent upon the presence of serology for DSA. So the presence of DSA is mandatory to be sure that the morphological diagnosis is compatible with acute antibody-mediated rejection, as in this slide, and in the same for chronic antibody-mediated rejection. So DSA is important to diagnose both acute and chronic antibody-mediated rejections. What are the risk factors for development of de novo DSA after transplantation? The blood transfusion is a risky business, and this is from French experience, showing that transfusion was there for 2/3 of patients in this study, and transfusion was associated with development of de novo DSA and antibody-mediated rejection. The choice of immune suppression drugs, induction and maintenance. Thymoglobulin is beneficial and it reduces the chance of development of de novo DSA. However, non-depleting non-depleting induction therapy may be associated with development of de novo DSA in the arena of sensitization. The early withdrawal of calcium inhibitor is not welcomed, and hazardous if there is sensitization. The early use of a mTOR inhibitor as well is associated with development of de novo DSA. So the presence of de novo DSA obliges us to be strict in our protocol, using the drugs in a meticulous way. And this is a very nice way to look at the tacrolimus level to avoid tacrolimus variability. So keeping tacrolimus within the therapeutic and avoiding the peaks and so on and off. So if there is coefficient of variation exceeding 30%, this is bad news because it is associated with hazard risk of threefold for development of rejection. Moreover, if we diagnose de novo DSA, we should keep tacrolimus level a little bit higher. So if the patients develop de novo DSA, we should keep tacrolimus level above 5.3, because as you see in the slide, if tacrolimus is dropped below 5.3 nanogram per ml, the risk for graft loss after development of and detection of DSA is significant. So again, we should keep our eye on our patients. If DSA is there, we'll continue our immune suppression, putting in mind we may do protocol biopsy later on, keeping immune suppression in an accepted way. What about the types? Here, this is regarding DP antibodies. If you look here, DP, donor-specific DP, is not present alone, and it is usually present with anti-DR and anti-DQ. It's very rare to be present here. However, in this study, they showed that the presence of both DP and anti-C antibodies are risky because they are correlated with acute rejection and as well associated with graft outcome. Regarding DQ antibodies may be prevalent from 5 to 60%, and the presence of antibodies against DQ may be a predictor for acute chronic antibody-mediated rejection, transplant, glomerulopathy, and can predict graft survival. And again, if the DQ, anti-HLA DQ is present by high concentration as reflected by mean fluorescence intensity, it correlates with the C1q binding. Regarding the binding with the complement, if antibody is capable of binding complement, the old dogma is binding complement is a very bad character and it can affect the graft survival, as you see here. If the antibody is capable of binding complement C1q, as you see, graft survival is affected significantly. However, this is a nice study that was published this month, showing that the presence of de novo DSA after kidney transplantation are associated with impaired graft outcome independent of their capability of C1q binding. This study included 600 patients who were subjected to evaluation to detect the presence or absence of antibodies, and antibodies either donor specific or not are evaluated to assess their ability to bind or not C1q. If we look here, the presence of donor specific antibody is bad news and associated significantly with acute rejection. Here, if we further categorize them into either C1q plus, so they have the ability to bind C1q, or not, there is no difference between those antibodies which bind C1q or not. The most important point is if they're donor specific or not. Again, there is no significant difference in the multivariate analysis between C1q binding and C1q non-binding, so the presence of donor specific de novo anti-HLA antibody is bad and doesn't depend on C1q. Here, regarding the evaluation of C1q status and titer of de novo DSA as predictor of allograft survival, as shown in this study, the most important clinical graft function and phenotypic pathology, and the non-adherence. So non-adherence is important than C1q status. So we should look at the clinical parameters, histology, rather than the complexity of C1q, because it will add the cost. Not only the cost, but even the technical. There are many technical limitations of the C1q single engine bead assay to detect the complement binding specificities of HLA antibodies. It may be not C1q but C3D because immunology is always complicated. And why it is complicated, because up to this moment we cannot measure the immune status of the patient accurately. We don't have an accurate immunometry. So looking at the 3D binding in this study, here the cocktail of donor-specific, de novo donor-specific anti-HLA antibodies, C1q binding, C3D negative, donor-specific antibody doesn't bind C1q and C3D. Here, C1q binding and C3D binding, as you see, the probability here is significant. This means that C3D binding capabilities, measurement of the C3D binding capabilities is important in transplantation. IgM type of antibody, here in this study, they showed that in the era of eculizumab, the use of eculizumab is essential for management of some antibody-mediated rejection, because it blocks the terminal arm, the distal arm of immunity, effective arm. Here they found 4 cases. This is the 4 cases here where the IgM is present. 2 cases developed acute antibody-mediated rejection, and 1 developed subclinical acute antibody-mediated rejection. Here, in the cases who didn't develop anything, antibody-mediated rejection, IgG only present in the serum. So this means that IgM, donor-specific IgM, may explain some resistant cases after eculizumab. What are the types of acute antibody-mediated rejection based upon the type of donor-specific antibodies? The donor-specific antibodies, as I mentioned in the beginning, either they are preformed or de novo DSAs, and according to the type of the of preformed or de novo DSA, we have type 1 and type 2. So type 1 is correlated with preformed and type 2 is correlated with de novo. As you see, even the specificity of donor-specific antibodies is different. This is the demography. As you see in type 2, it is against the class 2 mainly. And again, the graft survival is affected by the type of acute antibody-mediated rejection. If it is type 2, the graft survival is drastically affected. Again, another study, we have two types of acute antibody-mediated rejection. The first type is because of the presence of preformed, pre-existing DSA. It is usually occur earlier, and this is a second type of the type 2, which occurred because of the presence of de novo DSA. Again, type 1, the survival for type 1 is significantly better than type 2, so the donor-specific antibody, de novo DSA, leading to type 2 acute antibody-mediated rejection is bad news, because as you see, graft survival for type 2 acute antibody-mediated rejection is significantly lower than type 1. And again, if there is a component of transplanted glomerulopathy, the outcome is more and more complicated. Even this study, they showed that transcripts in the pathology may help by studying the tissues by microarrays. Here, natural killer cells, transcripts is more common with de novo DSA in type 2, interferon gamma the same, T-cell transcripts. All these are transcripts are more prevalent in type 2, and because of the presence of de novo DSAs. How to optimize interpretation? By using computer-assisted topological analysis of renal allograft inflammations, adds to the risk evaluation at the diagnosis of humoral rejection, because they put everything in the computer, digital monitoring, putting the inflammation, types of macrophages, etc. Adding the issue of preformed memory of the cell, add to the significance of the DSA. Presence of preformed memory of the cell is associated with higher concentration of anti-chill antibodies and bad outcome. Even looking at alloreactive interferon gamma T-cell by ELOspot can add a lot here. It is correlated with development of de novo DSA after 24 months. Here, if there is DSA, 7/8 of the patients had positive regarding the alloreactive interferon gamma T-cell ELOspots. As you see, there are a lot of complexities in the evaluation, in the immunological monitoring. I'm not recommending any of these because they are still tools for research to proper predict, so we are waiting the evidence, and they are costly maneuver. Regarding non-traditional antibodies, MICA, major histocompatibility complex class 1 chain related A, these types of antigens are not expressed on lymphocytes, so we cannot detect them by traditional cross-match using lymphocytes, and they can be detected by Luminex technology. As you see, the presence of antibodies against MICA antigens here in the kidney, heart, and liver transplantation, you can see either pre-transplant or post-transplant, these antibodies can lead to increasing antibody-mediated rejection and can affect the graft outcome. A lot of antigens can stimulate immunity. So these are the different antigens that can lead to non-HLA antibodies. As you see, these are the site, the intracellular, extracellular, the blood side, and extracellular, the media side. You can see here Berlican, which is cleaved to LG3, so we can have antibodies against LG3. Angiotensin 2 type 1 receptor, so we may have angiotensin 2 type 1 receptor antibodies, endothelin A receptor antibodies, ICAM antibodies. So this is the list of the antibody target, either angiotensin 2-1 receptor, endothelin A receptor, perlecan, endoglin, FACP ligand, ICAM4, etc. You can find here the articles published to the number of patients and experimental evidence of the value. In the presence of anti-endothelial cell antibodies, this is a study showing the antibodies against all these endothelial targets can affect the outcome, and this is endothelial cell antibodies associated with novel targets and increased rejection. Here I want to stress upon what is the difference between HLA antigens and non-HLA antigens. The HLA antigen are already expressed on lymphocytes and expressed on endothelium, so there are a lot of data convincing for that. But non-HLA antigen are usually hidden, cryptid antigens. They need stressful situation like ischemia, refusion, and injury to be expressed to stimulate immunity. So this is the big difference in the HLA and non-HLA. Again, this is another very recent review. Here, for example, the LG3, as I mentioned, the cryptid antigens, ischemia, refusion, injury stimulate the antigens expression, and this will stimulate immunity for the development of antibodies, and antibodies bind antigen, leading to these consequences. If we look at angiotensin 2 type 1 receptor antibodies and anti-endothelial cell antibodies, in the past, the detection of angiotensin 2 type 1 receptor antibody was very difficult because it was dependent upon biological methods. Currently, it can be detected by ELISA technique, and here if the antibody concentration is high, so if they exceed 17 units per ml, as you see, out of 20 patients, 15 patients had acute antibody-mediated rejection. And if the endothelial cell cross-match is positive, this means there are anti-endothelial cell antibodies. Here, out of 8 patients, 6 patients had acute antibody-mediated rejection. So it can add to the predictive capabilities. Let us to go directly to the guidelines, because guidelines are more wise. And this is the last guidelines regarding the issue of immune evaluation of the couples for transplantation. That was published in 2015. And this is one of the questions that was answered in the guidelines. In renal transplant candidates, what HLA antigens and the non-HLA antigen should be defined in addition to HLA, B, and DR, because HLA, A, B, and DR are the traditional antigens. And we can consider the mismatch, sex mismatch, because we have 2 antigens, one from the father and one from mother. This is very smart. The guidelines recommended performing human leukocyte antigen DQ, DB, HLA-C typing of the donor only when the intended recipient has HLA antibodies against those antigens. So by doing HLA typing for the common HLA A, B, and DR, and doing Luminex testing or whatever the test for detection the type of anti-HLA antibodies, if there are specific anti-HLA antibodies for target antigen like DQ, DB, or C, we should tissue type the donor toward the type of antigen to know why, to answer a question: is this antibody donor specific or not? Because it carries a big difference. The guidelines don't recommend routine typing for major histocompatibility complex when related chain MICA and other non-HLA antigen in either the recipient or donor. I don't know if the new guidelines will state a controversy regarding this point, but up to this moment I am not convinced